This is part 2 in a two-part presentation on diagnosis coding and documentation to support billing for Medicare therapy claims. In part 2, the emphasis is on documentation. At the conclusion of this two-part presentation, you'll be able to follow ICD guidelines to choose the most appropriate diagnosis codes for your therapy plans of care. You'll understand what elements are required in documentation to support therapy claims, and you'll be able to recognize coding and documentation examples that represent best practice. Information for this presentation comes from the ICD-9-CM official guidelines for coding and reporting and from CMS policy manuals. Legacy's policies and procedures regarding documentation, coding, and billing are written in accordance with CMS guidelines and regulations. Before we move on, think about why we document our services in the first place. There are several reasons that clinicians document their evaluations, treatments, and patient progress. The first one that might come to mind is reimbursement. After all, we talk almost exclusively in terms of what documentation is required for successful reimbursement, and that's the primary focus of this training. Documentation that supports billing is critical, but don't lose sight of the fact that documentation serves a strictly clinical purpose as well, to record the patient's condition, therapeutic needs, and the therapist's plan to address those needs. Daily notes and progress notes have the clinical purpose of helping the therapist keep up with the patient's performance and progress. Good clinical documentation is the best way to plan, implement, and reflect appropriate patient care, and it supports reimbursement. To most of you listening, documentation is a necessary evil. It's something that you probably don't particularly enjoy. But the truth is, your best patient care is less valuable without good documentation. So let's dive in and discover what makes documentation good. Documentation must show that there is a need for therapy. This is what's meant by medical necessity. And it must clearly show that the therapy provided is skilled, that the services require the unique skills of a therapist. We must show throughout the patient's episode of care that services are skilled and that the patient requires a therapist to provide the services. Medicare guidelines for documentation ask us for these elements. The therapy record as a whole should paint a picture of the patient's impairments and function. It should compare prior level of function in establishing potential and prognosis for change. It should offer justification for the type of treatment, the frequency of treatments, and the duration of the therapy episode. The record should reflect skilled services. Daily notes should support the time of treatment and the codes billed, and should clearly identify each specific intervention. We're going to look closely at each of these elements using examples that illustrate good documentation. Paint a picture means to provide enough specific information about an individual patient that someone reading the chart could get a mental picture of that person's functional abilities. For example, all patients status post hip replacement have similar issues during recovery, but they don't all have the same history, the same prior level of function or recovery process. Specific rather than generic or vague documentation is what allows a reviewer to see the differences between one patient whose status post hip replacement and another. To paint a picture means to provide clear, descriptive information about your patient's current status. Use functional descriptions and objective measures. It's not sufficient to state that a patient has deficits in balance, gait, and strength. Describe how those deficits impact function. For example, the patient is unable to complete dressing and standing due to lower extremity weakness and decreased dynamic standing balance. Patient descriptions should answer questions about why the patient needs therapy. Is it to be able to return to a previous living environment or move to a new one? Is it to reduce the level of assistance required for basic or instrumental ADL? Here are two examples of statements that describe how therapy will impact patient function. Functional descriptions are based on observation and assessment of a patient's performance. The use of min, mod, max regarding assistance should be supplemented with a why, indicating the reason for and nature of assistance required. Legacy expects evaluating therapists to use objective measures of a patient's function. These include standardized measures, such as the Berg Balance Scale, the Allen Cognitive Level, or a 6-minute walk test. Most of these measures can be taken by assistants as well. Initial objective measures can be compared to later measures to show change. They can be compared to norms to demonstrate how the patient's function compares to age and gender cohorts. Medicare and other payers expect to see objective measurements rather than descriptions such as minimal, moderate, or severe. Here are examples of objective measures. Remember to provide normative or explanatory information so that the patient's performance can be put into perspective. In the first example, the therapist indicates that the patient's Tinetti score relates to a high fall risk. In the second example, although there is a lot of good objective information, it would be helpful to know that the performance shown on the 9-hole peg test is well below the norm for subjects of any age. Finally, objective measures make goal writing easy. Therapy documentation must demonstrate that the therapy provided is medically necessary for the patient. The evaluating therapist must assess the patient's current status, compare it to his prior level of function, and to what is reasonable to expect the patient's function could be. Medicare requires that patients should exhibit a significant change from their usual physical or functional ability to warrant an evaluation. Notice that the requirement is that the patient should exhibit change from his or her usual functional ability. It doesn't state that there must be a decline in function. Simply stating decline in function does not adequately justify the initiation of therapy services. So, include specifics such as the area of the body involved and other conditions or contributing factors that could impact treatment. Whether a service is skilled depends on the nature of the service provided. Services that require the application of specific knowledge of physical or cognitive function, decision-making or problem-solving that only a licensed therapist or assistant can perform are skilled services. But just because a licensed therapist or assistant provides the service, that doesn't make it skilled. If a non-therapist could lead the patient through the same task or activity with the same outcome, the service is not skilled. In order to meet Medicare coverage requirements, the therapy record should show that services provided are skilled. Daily notes and progress notes should include these components. If treatment interventions are skilled, it should be relatively easy to document them as such. Here is a general outline of what reflects skilled intervention versus non-skilled intervention. Exercise should be conducted and advanced based on an established protocol, such as strengthening using the 1-rep max or progressive exercise tolerance based on an initial 6-minute walk test. Treatment notes or goals that reflect the same exercises repeated session after session do not demonstrate skilled intervention. Instructing a patient in the use of compensatory strategies, such as techniques for safe swallowing, is a skilled intervention. Observing a patient at a meal day in and day out and only providing cues to use the technique is not skilled. Speaking of cueing, the type and frequency of cueing should be based on patient performance. It requires the skill of a therapist to adjust the manner of cueing during a treatment session or as an episode of care progresses. But if treatment notes indicate the same level and type of cue session after session with no change in the treatment plan, that is no longer skilled intervention. Skilled treatment requires adjustments to be made during individual treatment sessions, not just when the updated plan of care is due. A therapist uses clinical decision-making to adjust the pace of an activity, the number of repetitions, and demands made on a patient during each treatment. A daily note that reads the same, treatment to treatment, doesn't reflect skill, nor does a plan of care with short-term goals that never change. Daily notes that include these components reflect skilled treatment. Notes should be specific about what took place during the treatment, whether the patient needed assistance or cueing, and why he needed assistance. Indicate the patient's response to the treatment. Was accuracy better than last session? What about the quality of movement or the speed of responses? Tolerated well is not a sufficient indicator of the patient's response to treatment. In the next few slides, you'll see some daily notes that reflect skill compared to ones that don't. In the example on the left, the therapist provides information regarding the specific exercises, the weights used, and the number of repetitions. The note also gives specific information about the patient's performance. It's almost impossible to read this note and not imagine a patient performing the exercises described. The top example on the right is a generic statement. There's no information to help us form a mental image of the activity. The example at the bottom right includes specific information about the resistance used, but we don't know which extremity was being exercised or the patient's response to the treatment. On the left is a clear description of specific aspects of the treatment session. Look on the right. A description of the postural problems the patient needed cues for and a statement about the patient's performance could make this a note that reflects skill. As it is, the lack of specifics makes it a note that a non-therapist could have written. In the note on the left, it's clear that the patient is working on weight shifting during transfers. The other note could reflect skilled treatment if there were information about why and how the therapy and sanding activities were used. The note on the left tells us what level of assistance the patient required, the type of cueing provided and why, and that the therapist provided instruction and demonstration in the proper use of a reacher. On the right, the picture we get is of a patient who required no intervention at all, skilled or otherwise. The skilled note identifies the reason for the exercise completed, the nature of patient education, and how the patient performed. The non-skilled note provides none of that information. Here, the non-skilled note identifies the activities completed in the treatment session, but it doesn't provide any specific information regarding the tasks, instructions given, or the patient's response to the treatment. All of those aspects are present in the note that reflects skilled treatment. Even a note that reflects skill the first time it's written can fail to support the skilled nature of therapy if it's repeated. Our electronic documentation system allows therapists to copy and paste a previous daily note. That function is a great way to quickly repeat certain aspects of a patient's treatment, such as weights and reps. But if a patient is truly performing exactly the same session after session, he's either ready for a change in his treatment or he's ready for discharge. Medicare coverage depends on medical necessity. If a patient performs at the same level over and over, chances are it doesn't require a therapist to elicit that performance. And here's a quick caution about billing your treatments. Many of you are familiar with the 8-minute rule, which states that at least 8 minutes of treatment must be delivered to count as 1 unit. 15 minutes plus 8 minutes, or 23 minutes, counts as 2 units. 30 minutes plus 8 minutes counts as 3 units, and so on. The best practice is to keep up with the actual minutes you provide for each service or modality and record it accurately. It's possible that every treatment session with a particular patient lasts exactly the same number of minutes every day, but it's not likely. Instances of billing 23 or 38 minutes day after day, especially with poor support in the daily notes, is suspect. Remember, we need to show that there's been a change from the patient's usual level of function. Indicate when that change occurred using a date or time reference to tell when the patient last performed at that prior level of function. Remember to be specific and use functional terms and objective measures when possible. Take a look at these samples regarding prior level of function. Do these statements describe function in an objective, measurable way? Do you have sufficient information to help demonstrate potential for progress? The first example only tells where the patient lived before. The second example offers some functional information. Did you get a mental image of the patient by reading either of those statements? Me either. But look at the final example. It's easy to picture the patient being a bit wobbly when she first gets out of bed, but then being able to walk by herself in her room or across the hall. This is a good explanation of prior level of function. The progress notes and updated plan of care provide a summary of the treatment documented in the daily notes. As with daily notes, these notes should contain specific, objective, and functional information regarding the patient's progress and current performance. Specific, objective information is the only way to support continued services. Beware of only using the canned statements from SMART about adjusting the plan of care and decision making. Explain what decisions you made and why. How was the plan of care changed and why? In this note, the therapist doesn't stop at stating that functional gains are apparent. She backs it up with objective data related to specific treatment areas. Furthermore, she gives a clinical rationale for continuing therapy. In this assessment of patient performance, the therapist uses functional information, scores from standardized tests, and objective data related to strength. The key to good documentation can be summed up this way. Tell the story of your patient. Why does she need therapy now? What happened, and when did it happen? Use specific descriptions and objective assessments to show the patient's level of impairment and to write functional goals. In daily notes, be specific about the interventions and activities so that someone reading about your treatments could picture your patient performing those tasks. In progress notes and updated plans of care, refer to progress toward goals and make predictions about the patient's potential to reach them. Explain why therapy is needed to improve your patient's function. Creating good documentation doesn't have to feel like the proverbial square peg and round hole. Just tell your patient's story in a way that only a clinician can. The necessity and skilled nature of your services will be apparent to anyone who reads your patient's story.